Well, this is very fun. It's awesome to be here with you, Evan. And audience, thank you so much for joining. We hope that you walk away with some valuable information about how you can turn patient voice into volume. Um, so here we go. So just some brief introductions. I'm Breanna Cunningham. I am the CEO and founder of Code Technology. We collect patient-reported outcome data for hospitals and private practices all around the country, predominantly in ortho. Our mission as a company is to help our clients collect, use, and love outcome data. And Evan, I'll let you introduce yourself.
My name is Evan Steele, CEO and founder of Raiderate. I started the company in 2015. And today we have 15,000 providers on our platform around the country. And the big difference is we're healthcare focused. So we really know the space and healthcare online reputation, and that's where we excel.
Awesome. So the structure of today's webinar, we want this to be interactive. So please use the chat format to ask questions, and we'll make sure to do our best to answer those. So we're going to start by both kind of introducing what we do and why we are unique. So Evan will talk first, then I'll take over. And then we're going to dive pretty deep into the CMS TKA PRO-PM. And as that relates to the outpatient world. There's been a lot of questions that both Evan and I have been fielding on this subject, and just thought, heck, it just makes sense to do a webinar and have kind of some global education on it. So with that, Evan, I'll turn it over to you to talk about reputation management, what you do, why it matters. And you already honed in on some of your differentiators, but I might ping you with some additional questions.
Yeah, so just a couple of slides here to give an overview. This is really about what I'm and everyone is really concerned about is what's coming down the pipe for patient-reported outcomes and CMS and all the requirements and bonuses and penalties and whatnot. But online reputation is just like patient-reported outcomes. It's all about feedback from patients and using feedback to improve the patient experience and patient satisfaction. We look at the one word visibility, right? So it's so important these days that patients just when they use Google or Bing or any search engine and just search for best orthopedic surgeon in my area, what's my best knee replacement surgeon option in my area? Oh, I got the name of this doctor from a friend or my primary care physician to use for my orthopedic consult. Let me search for that doctor. What does this doctor look like online, and do I trust this doctor, right? So we want to build not only credibility and trust online, but visibility, meaning we want to take all sorts of patients' feedback, and which is overwhelmingly positive typically, and publish it online. So the search engines, especially the AI like ChatGPT and Gemini, when you ask questions like, is Dr. Smith a good doctor or a good surgeon, that you get a really good answer that accurately reflects what patients feel about this doctor. And isn't just some random comments that have been posted around the internet that don't paint a favorable picture of that doctor. So again, it's all about visibility, taking patient feedback and making it visible to search engines and the AI large language models as well. And then why it matters, obviously, if you're more visible online and you're creating credibility and trust among your patients, you're going to gain new patient volume, gain and retain patients over your competitors. So it's just a very highly efficient way of investing your marketing dollars. And then on the internal side, we actually have employee satisfaction surveys to build better organizations and address any pockets of dissatisfaction among employees. And that turns out happier employees put nicer reviews on Glassdoor and Indeed. So when somebody's looking to work at your organization, that also looks good online, right? Whether it's a new doctor you're trying to attract to work for the practice, or it's a new employee when you're competing with the hospital down the road, or the hospital's competing with an independent practice down the road, that their online reputation looks good. And it's all about efficiency. Everything's about efficiency, right? Lots of patient feedback. Lots of employee feedback. How do I distill it down so I could, again, identify pockets of dissatisfaction and identify pockets of extreme satisfaction and areas where employees are of the practice are receive shout outs from patients, and so how could I use it to both engage and excite my employees and also identify areas where I need to improve. So that's why reputation management matters. And just a quick
Question
summary.
for you, Evan,
Yeah, go
about
ahead.
this.
Sure.
You mentioned ChatGPT and you mentioned Gemini, and the landscape has evolved dramatically in the past couple of years, and how we search, how we find information has changed. Even how information is that we're searching for comes, into our inbox has changed. Talk to me a little bit about that evolution and how you've been able to stay on top of it.
Yeah, so Google, if I say, what is Google? Most people say it's a search engine. It's no longer a search engine, it's an answer engine. People aren't searching for links to pages, they're looking for answers. So you could ask, something current, today's news, what's the tariff rate on India, right? I think they just changed it to 50%. And it used to be a bunch of articles would come up and you could click and read the news and try to figure it out. But now Google just summarizes that data in an AI overview and tells you exactly what the tariff percent is. It's the same thing in medical. It's the same thing about doctors' reviews. It's the same thing about procedures. So there's been a sea change in the way search engines work, and they're now becoming answer engines, right? And this trend's not going to stop. Some people might not trust it now, but it's here. It's the answers are getting better and better. I use Google as my search engine, and therefore they use their Gemini, and it's just always looking for answers. So how do you adjust your visibility of patient feedback so that you could feed the AI large language models, the LLMs, so you could feed their models with content. So when a patient or prospective patient asks a question about a procedure, the practice, the doctors, um, the AI overviews and summaries will come out looking good for your practice. So it's very different than just trying to get you highly ranked in an SEO search, and it's called GEO, right? Generative engine optimization instead of search engine optimization. So we've had a big shift here at Raider 8 of being GEO centric, and that's the developing trend, and it's not just a new little fad. The Google answer engine or the online answer engines are here to stay. So how do we change patient feedback visibility to accommodate these search engines or these AI engines?
Sure. Right. I mean, that's amazing. And one of the reasons that I love your product is how focused you are on what you do. That has not changed, but how you do it has changed. And you're experts in this evolution of what's happening in the market and how do we continue making sure that reviews are front and center and that your clients have the ability to take that data and turn it into action.
Correct.
Anything you want to comment on this lovely slide, Evan?
No, just I'm a little bummed out. If there's anyone from Vermont, we don't have any clients in Vermont, but we have Hawaii and Alaska, we have, and all the other 47 other states. So we do have a nice national footprint. We're in 68 different medical specialties, large and small. Our largest client, we handle over thousands of listings for them, and our smallest client, maybe one doctor practice with just one Google listing and a health grades and a vitals listing. So, we support online reputation is kind of democratized, like any specialty, any size practice. Just like SEO is part of any good marketing program, so is online reputation, making your patients' positive feedback visible online, and that applies to everybody. So we have a very nice client base, but you'll notice from the logos below, a lot of our clients is orthopedics, and we have a lot of folks from orthopedics today. I say about 40% of our clients are orthopedic practices.
And Evan loves maple syrup and Ben and Jerry's. So for people listening that are from Vermont, you will be there for an on-site if you choose Raider 8 for implementation.
Here you go.
All right, so I'll talk to you a little bit about code technology. So code stands for clinical outcomes and data engineering. And we are experts in all things related to outcome data. And the problem that we solve for our clients is the patient-reported outcome data collection. Outcome data, there's lots of facets to it, and patient-reported outcome data is becoming increasingly popular in research and FDA approval and embedded into value-based payment models. So, Evan, do you smoke?
No, I do not.
Okay, there you go. That's a patient-reported outcome, right? So
Hmm.
there's a lot of confusion over what's a PRO, what's a PRO-M, what's a PRO-PM. So if you ask a patient a question, they give you an answer, that's a patient-reported outcome. PROM, so PROM, you'll see that, is a validated survey. So think like a Myers-Briggs or a DISC personality test. These are validated survey tools that have a quantifiable score that will tell you how well your ACL is functioning or how well your hip arthritis is progressing. So the cool thing, I mean, it's the cool and also challenging thing about patient-reported outcome measures is that there are lots of use cases. When I first started code, also in 2015, so look, Evan and I are contemporaries on that front. I thought the predominant driver for people signing up with code would be for research. That was my biggest driver, is using it for not just retrospective but prospective studies. I'd say that probably represents 3 to 5% of the reason people sign up for code these days. The most organic reason is that if you think about, especially in ortho, patient-reported outcome surveys quantify pain, function, and your quality of life score. Why do people see orthopedic surgeons? To improve pain, function, and quality of life. So it's a great way to just track how they're doing. It's great for benchmarking and internal quality. And people use it for even talent recruitment. And most of the young guys or gals that are just coming out of their surgical residency, they've been using patient-reported outcome data. And if you have a great program where you're collecting and they have access to that data, it's a great way to recruit. But one of the reasons that we're here today, and I would say, probably dominates 80% of the conversations that I'm having with the world these days, is the PRO-PM. So we're going to spend some time on that. Similar to Evan, I don't know if we have remote clients too. Maybe someone from the code team that's on can check and see. We're all across the U.S. We are not outside of the U.S. at this point in time. We serve hospitals and private practices. Right now, our hospital clients, we have more hospital clients than private practices, and that's related to where we're at with the CMS PRO-PM. We are known for ortho. 80% of what we do is in ortho. That being said, we are service line agnostic. And the way our product works, as long as there's an anchor event that we can define, we can administer PROMs and outcome data collection around that anchor event. So why are we here today? Before we really get deep into the measure, I wanted to talk about how the Rate and the code team work together. So I'll start, Evan, and then don't hesitate to jump in here. So, you just heard Evan talk about Gemini and about ChatGPT and how nuanced this world is and how much you have to be focused on these changes that are happening quickly and sometimes are building the ship at sea, where we don't really know what this is going to look like, but in order to continue to evolve our product, we have to understand it and become experts in it. Prompts are the same way, whether it's the licensing requirements around a survey or understanding the government requirements, all BUCA, especially CMS requirements related to PROMs. It is a full-time job plus just to keep on top of it. So as we were thinking about how we can deliver the highest quality product for our clients, we get asked at Code all the time, can you do reputation management? Can you do online reviews? I mean, we can sure send a patient an email to a link to give a social review, but that is not what Evan does. That is not what Rate does. That's not, I mean, that's so far below the caliber of what they do. And while Evan's product can administer a patient-reported outcome survey, what we do is on a different scale. So we were thinking, how can we make sure we're offering the highest quality product to our clients, and continuing to have that narrow focus on being experts instead of being, jack of all trades and masters of none, continuing to be masters in our respective realms, yet allowing our clients to benefit from having true experts in these two very important modalities that drive growth and revenue for their practices. Anything to add there, Evan?
No, we continue.
All right. Okay, so who is ready to talk about the CMS, THA, TKA, PRO-PM? See how it's a mouthful, right? THA, TKA, PRO-PM. We learned from a code employee, Kristen Templeton. I'll even call her out here, so when it gets in your head, you can yell at her on LinkedIn. It as perfect jangle to that Mickey Mouse song, right? So this measure, it dropped in 2022. Well, the proposed measure dropped in 2022. I did not author it. People ask that a lot. Was code behind this? No. I read it like the rest of the world. At first, I had two feelings, two very dichotomous feelings. The first was, yay, I love the measures that they chose. I also love that it's pre-op and 1 year post-op. So it's total primary total hip and total knee patients. And as an outcome nerd, I love the 1 year interval. I think that is the best interval for defining whether or not arthroplasty was effective. But then I thought, put my hospital hat on, and my jaw dropped. How the heck are hospitals going to do this? 50% capture rate is not a walk in the park, folks. We do a lot of kind of replacement business where we're coming in and taking over where another vendor was working. And the best I've ever seen at 1 year is 30% prior to this measure. And the average is usually in the single digits when we're doing a takeover. So with this measure, there are kind of two big constructs, okay? The first is the data completeness. So you have to have a complete data set pre-op and 1 year post-op, okay? To meet the reporting requirement. Just to unpack this a little bit further, so it is a 50% capture rate requirement for that PROM at 1 year, 45% for the outpatient, okay? And if you don't meet that, you fail all of your CMS QR reporting, okay? There's a lot of measures that are in there. This is just one of them. But it's wild because most of the measures out there are extraction measures. So it's things that you're kind of already doing in your EHR, you have to build a new report for. What's unique about this is it's not something that you build a report for. You need the patients to fill out a survey 1 year after surgery, and they're not following up at your hospital, right? So it's definitely a first of kind. People are really starting to feel the pain of this and develop systems around it. The hospitals have been we are in the second mandatory performance year for hospitals. Okay, so 2024 was that first performance year for hospitals. The first reporting is in September, so that's going to be a very interesting time. I'm happy to report that code clients are in top shape. We're prepared, but that's kind of where the rubber meets the road, if you will. So let's talk about when it trickles down to outpatient. So they gave a bonus voluntary year in outpatient, but the outpatient requirements are very, very similar. The only thing that's different is for outpatient HOPD setting, the 50% capture rate is the same as the hospital. So both are 50%. For some reason, they decided to shave off 5% for the ASC market. So 45% is the capture rate. Before we get into timeline, let's talk a little bit about the other aspect of this measure. The market right now is very focused on the capture rate, which doesn't surprise me. And the reason why is that's where the financial penalty really, really hits, okay? So for the hospital setting, it's 25% of the annual payment update. For the outpatient setting, it's 2%, okay? So depending on your market and your Medicare population, this can be, millions of dollars, okay? So if you fail reporting, that's where you get the penalty. So let's talk about the other aspect of the measure. So this is the substantial clinical benefit. So what this is they're collecting, as part of this measure, they're collecting the who's and the who's, which are functional improvement scores, and they're scored like basketball. So the who's and who's are 0 to 100, right? Where 0 is bad, 100 points is good, and they're looking at the delta, so the change in score from pre-op to post-op. They're using what's called the substantial clinical benefit that they've defined as a 20-point change for knee and a 22-point change for hips, okay? And they're going to take every patient that you've operated on that meets the criteria and say, did they meet a 22-point, yes or no? And then they're going to roll that up as a percentage, and that's what's going to be reported publicly via Hospital Compare, okay? So that is there's no financial incentives tied to that yet. That being said, we are seeing this trickle down into models such as TEAM, and I imagine that more of these value-based programs, value-based purchasing, will start using that. Okay. Any questions or things you think I should cover here, Evan, that would help especially your clients that are on this webinar?
Yeah, we notice at rate or rate different response rates among different demographics, income demographics. So I wonder, when you get into a demographic that doesn't typically have high response rates, what's your strategy to make sure you get to the 45 or the 50%?
Sure. That is a great question. And I'm going to challenge this thought process a little bit. So coming to a New England Journal of Medicine Catalyst article near you in the very near future, it's a study that was done on the code registry, which it has more than 300,000 patients that were a part of this study, looking at variation in capture rate for this particular measure well, not just this measure, but THA, TKA, PRO-PM. Okay, and we sliced it into 2 different years. And the purpose of this study was to go after what are the social determinants of health that impact capture rate, okay? That's what we sought out to do. It was a prospective study, and guess what we learned? There wasn't variation. And what's kind of funny is that the authors were a little bit pissed because they're like, dang, we really wanted to have some meat here. But they decided to then turn this into a New England Journal of Medicine Catalyst study as more of a, okay, what is code doing to make sure that there isn't variability? So I think that, and I don't mean this in a mean way, but you need to adapt your processes as it relates to how you communicate to patients and how you obtain the survey data. But if you do that properly, you shouldn't see variation. You shouldn't see variation. And I think one other thing that's kind of funny is people think, oh, academic centers actually have, they have the resources, they have the best capture rate. In the code system, the academic centers actually are not the highest performers as it relates to capture rate. So it's something that you need to consider and you need to tailor your program according to, but it's not an excuse not to get a high capture rate. And on that note, I get asked the question a lot, Evan, is, do you think CMS is going to lower the response rates? And my answer to that is no, and here's why. Many of Code's clients participated in the voluntary period, and their capture rate's a lot higher than 50%. So I don't say we ruined it for everybody, but that's just gonna, they're gonna say, well, why can't you? All right, let's talk a little bit about the timeline for outpatient. So we know that the inpatient is in effect. So your hospitals, or if you are a hospital, you are collecting. So we are in the second performance year for hospitals right now. Again, rubber meets the road. D-Day happens in September, where there's that first reporting period. For the outpatient setting, we are in the first voluntary period right now as we speak. Okay, that started on January 2026. They have 2 voluntary periods for this measure, which is interesting. I don't know why CMS did that, but they did. So technically, you don't start the mandatory reporting until 2028. Okay, but those are procedures that start on 2028. So let's kind of back into this timeline a little bit. First, I definitely recommend that you participate in at least one of the voluntary period. What happens in the voluntary period is your data is, you submit your data, and then Medicare gives you a report that is not public, so you can kind of see any holes or gaps in your data. For any of you that have participated in any Medicare program, you understand the value of this. In the mandatory period, it's everything is publicly available. So I first encourage you to participate in both, if not one, of the mandatory period. So then let's back into, when do I need to start collecting if I want to participate? So it's procedures that start the first of the year, okay? So the pre-op window is 90 days, okay? So you're allowed to start collecting surveys 90 days prior to the start of the year, right? If this were me, I would at minimum want to be live for 6 months before the performance period started. Okay, so if the performance period's in January, I would want to be collecting no later than like April, June, the previous or that of that year, to make sure that my system is working. Okay. The other thing I want to mention here, I didn't plan on talking about this, but I had a conversation right before this on the topic, and I think it's important. You can learn a lot if you're a private practice. You can learn a lot from what the hospitals are going through right now. One thing that's unique about this measure is the reporting period is far removed from the procedure period, okay? So the procedures that were done last July are being reported on in September. That's a huge gap. So if your system is not working, you have to find a new system, and you're living in 2 worlds, right? So if you switch vendors midway through, you're living in 2 worlds as it relates to reporting. And I promise you, from just a tracking and a logistic and an admin perspective, having 2 systems is a challenge. So just something to consider. This is the first PRO-PM. The second one has already been introduced. That's called the Information Transfer PRO-PM. And CMS, it's bipartisan. CMS has made it very clear, this is the way of the future. They're going to continue rolling out PRO-PMs. This is just a timeline of what's happening, what's already been proposed. There's rumor of spine that's coming out soon. So what's important is for people in this audience is just to start thinking about, how do I scale this? How do I build an infrastructure for ongoing sustainable data collection that's reliable, that can meet not only my internal needs as a practice and my quality needs, but ensure that I'm able to meet all the requirements for reporting and CMS and BUCA alike. So with that, as you're thinking about what questions you should be asking and how to prepare, I think the team will put this link in the chat. There's a QR code of just questions that you should be asking vendors. I will say, we talked earlier about being a jack of all trade and a master of none. The market is very opportunistic, and when CMS requires something, all of a sudden a lot of vendors will say, oh, I can do that. Just do yourself a favor, make sure you're asking the right questions, because you don't want to be midway through. You want to choose the right vendor and not have to switch. So I think now we are on to Q&A. So maybe first I'll start with you, Evan. I know that was a lot of information, but a topic I'm very well versed in and happy to dive deeper on any subject.
Any burning questions? It was a clear presentation. So maybe there's not.
Well, thank you. We just got one that says, why should hospitals invest in PROMs now or not hospitals, but why would a private practice? Because hospitals, if they're just starting to invest in PROMs, listen, they have a world of hurt coming, right? Because they've been in the mandatory period. But if you're a private practice that owns an ASC and you don't have to do this until 2028, why not wait? I mean, we're all trying to save money, so why not wait? I would say, for me, that I have a lot of feelings on this subject. First off, a year from now, the entities that will have the most access to PROM data are the payers. Okay, so they're going to know more about your scores because they're already being submitted through the hospitals than you will. And they're going to start designing policy and quality metrics that really impact your world and how you were paid without your insight. So, he who owns the data, has access to the data, controls the narrative. So I'd be thinking about that. Understand your scores, understand where you're at before it's kind of dictated on you. So you can have a voice and you can just prepare. So I think that's a big part of it. The other thing too is I think, we're talking kind of reactionary and this is a penalty situation. There's a lot of things that you can do and leverage the data in a way that it's not just because it's required, but in a proactive way to negotiate with payers, to package your data and get better rates. So there are things that you can do to grow your practice. Outcome data takes a long time. I always tell our clients, it's like watching paint dry, okay? Until you have a significant amount of pre and post-op data where you can produce the delta, you can't really do much. And here's also the reality. Once you have that data, everyone thinks their data is great, right? Like, oh, I'm great. We have the best outcomes. And they're looking at their data and they're like, okay, I'm performing okay here, but I have work to do here. So 2 years is, if you're not collecting right now, start now. And then by the time that it hits your practice, you will have had enough data to ensure that you've worked through all the kinks to optimize and make sure that your scores are competitive. All right, so we have a question. Does code talk with other systems as a PIQ? So Patient IQ is another PROM vendor. They collect PROs, but we don't necessarily like PIQ. We integrate with all the EHRs, but we don't typically, people are usually using one product or the other, if that makes sense. Rich, did that answer your question? And Evan, you can comment on this too. I know this comes up in your world as well.
No. That makes sense.
I mean, and you know what, Evan, I remember us talking about this years ago when I did us. One thing, there's been a lot of things about CMS policy that Evan and I converse about intensely that we're not super excited about. But one thing that has been pretty good is the fact that CMS mandated that we all exchange data and are able to communicate in a nice way. So when it comes to interoperability, being able to communicate, any vendor out there should be able to throw up an API or communicate data between systems with the right paperwork in place. So interoperability, exchanging information has become more standard, and any competent vendor should be able to do it. Right, Evan?
Mm-hmm. That's correct. So speaking of other vendors, Gina says they get PROMs built into their EHR, which is Epic. What would code add that Epic is not doing already?
Yes. So Epic, The biggest failures that I'm seeing right now are those where the EHR has been the source of data collection. And here's why. They make it very, I mean, Epic doesn't necessarily, I mean, they don't really, I'll say, play nice with others. They always want to kind of, people want their EHR to be their source of truth for everything, which I understand that concept, but it's not always practical in real life. Epic does have the surveys out there. So they have the ability, oh, we have a COOS survey, cool, and that's free to use. What they don't tell you is then you have to build out custom software. You have to build it. You have to program how you take that COOS and tie it into your systems. I've seen it not be scored correctly. I've seen very, very low capture rate. It's dependent on people having access to my chart. You're not able to benchmark data, so you only get the patient scores. But I mean, unless you're like me and you're working in this data every day, Evan, do you know what a COOS of a 40 looks and feels like? Right? So without the benchmark and the data to say this is how it compares to the rest out there, it's kind of meaningless. Extracting the data for reporting requires an analyst. So this is a real story. I'm not going to say a client name, but we did an implementation pretty recently where they were only collecting, they weren't even outside of orthopedics. They were collecting on a couple cohorts within their orthopedic service line. They had 30 IT members assigned to their PROM management. Okay, their capture rate was what? It was not that bad. It was like 30%. But the ongoing resources that are required to manage PROMs, whether it's licensing or scoring or reporting to other entities, is very intense. And EHRs aren't designed to do that. They have the actual survey, well, cute, but then you have to build out the rest of the infrastructure and keep on top of it.
Mm-hmm. So just there's a couple more questions, but Gina, just to follow up to her one that she just had, can you comment on PROM data helping with payer negotiations or building value-based care contracts? That was an easy one.
Yeah, I mean, people want if you're in the game of a prospective sort of value-based arrangement, PROM data is your friend, and understanding your outcome data and baking that in is huge. So I would say probably we have clients that are doing that, and I mean I love working with those clients, kind of entrepreneurial, right? And payers like it too, right? And payers are, it's very regional and very specific on the payer of what their level of interest is in coming up with some sort of custom arrangement, but it's out there. If you have an appetite for it, it's out there, and your PROM data helps. The other thing is, I'd say with workman comp, that's been a huge area where our clients have been able to negotiate better rates because they're able to show through their outcome data, the functional improvement scores saying this person's able to go back to work, especially with municipalities such as police and fire, where it's important that they return to their same level of physical function. You have good outcome data and you can show that you're performing above codes registry, leverage that and they'll listen.
Mm-hmm. Okay, so a question from Rich Anderson. So Rich says, ask this question in the event that the clinic decides to switch. He asked the question about switching midstream, the patient IQ reference from patient IQ to code. How do you handle that?
Okay, so there are 4 options. So as it relates to, I'm going to talk specifically to the THA, TKA, PRO-PM. Okay, if there's no measure requirement that's there, it's pretty simple. The process is we just export, we go live, we import the data from the other system and pick up where they left off. Let's talk about as it relates to the THA, TKA, PRO-PM. Okay, there are 4 options that are available. The first 2 are kind of do nothing, where it's you just, we pick a date. Okay, and they stop data collection on one side, code starts, but they finish out all the patients that are pending in their system. That makes sense? Okay, so they're still responsible for all the patients that they've enrolled prior to code going live. Then it gets into the options where it's kind of a mixed bag, where it's code takes over just the post-op data collection. Okay, so we're importing the procedures, but not the surveys, and we're just doing the post-op data collection. Okay. While that helps alleviate the burden of the practice or the hospital of obtaining the post-op surveys, which people are glad to offload to code, it doesn't allow you to track the reporting and if you're on track with the measure, right? So we have all sorts of beautiful dashboards in our system that allow you to see exactly where you stand if you're meeting the requirements. If you go down that option, you can't see the parent, so you're responsible for kind of merging the data sets. The fourth option is that we're importing your surveys and your procedures and kind of picking up everything where you left off, so everything lives in the system. Naturally, from like 1 to 4, there's different prices, right? But there's a lot of considerations, which is why, I mean, that's a great question and something that I would encourage people to really think about. The switching cost for vendors is always real. As it relates to the THA, TKA PRO-PM, it becomes more expensive. So there's a real penalty on the line. So be very thoughtful about the vendor that you select, and make sure they can meet that capture rate requirement, and ask them what they're going to do about it if you're not meeting.
Mm-hmm. Okay, great. So James Duffy has 2 questions about kind of the nuts and bolts, how things work. So first, does code pull data will require the facility to pull data from to provide the data from the EHR?
Yeah. So our goal at Code is always to kind of be the source of truth as it relates to our client's registry. So we're building a registry for our client. So we integrate with your systems and we extract all the data into our systems. So then you can do all your reporting out of Code. And for the most part, if you look at our kind of data dictionary, we're pulling all sorts of patient level, procedure level, risk data that allow you to run really great reports, but also will meet the program requirements for other registries and payer bodies. Now, every now and again, there'll be something such that requires us to go back to the drawing board. It's pretty rare, but I'll give a tangible example. The specs for the THA, TKA PRO-PM were not that bad. We were sweating waiting for them to drop. They weren't that bad. But there was one thing in there that was unique, and this was the provider reported narcotic question. If there's anybody from the Code team here, they're like shake when they hear that word, because it was like none of our clients had a system. It wasn't a standard field in the data. It had to be provider reported, so we couldn't pull it from prescription registries. And everyone had to kind of develop a new workflow of how they capture that data. Now, we worked with our clients to do it, and they've had it. So every now and again, James, a measure will come out that has a requirement that is not a standard part of any EHR that we have to work through together. But I'd say from an 80-20, I kind of look at life as an 80-20. That's a 20%, maybe a 10% of the measures that we see come out require that.
Mm-hmm. And then James has a follow-up. When you send the surveys, it's just 2 questions. Are the email text notifications, and is there a way to get the data back into the EHR?
Right. So we communicate with patients in 3 ways: via phone, like true phone calls, and just kind of, if you're taking notes here, especially if you're thinking about doing this manually, 7% of the patients in the Code system that are totally require a true phone survey. So not just a reminder call, but us taking them through. And then we communicate via email and text as well. And the second part of that question was, does the data go back into the EHR? That is a great question. So let's talk about that. So first, it's always going to live in the Code system, right? So you log into the Code system, and there's several ways to make it easy to get into the Code system from your EHR, such as SSO. But all the data, the benchmarking, the ability to risk stratify and run reports lives in the Code system. Can we send it back to your EHR? James, we can send it anywhere you want. You tell us what the specs are, and how you want us to get it over, and we can. But I want to take a moment to talk about some of the limitations with EHRs. And there's, again, we could do a whole webinar on this, but with EHRs, the PRO realm is kind of new to them. So let's just talk with Epic, because that's pretty common. There's 2 places in Epic that it makes sense. There's a flow sheet where we can put the data into, and we often will put the PDF reports into a media tab so they can see the benchmarking, okay? Let's talk about Athena for a second. Athena doesn't have a good way at all to really handle the PRO data. So right now, there's kind of standard practices that you plug it into a lab value, which then goes into the patient record. So it's EHR specific. And I would also say too, the phrase I like to say here is, once you've seen one, you've seen none, right? So it's important, even if we have lots of clients on Epic, before we send data back into Epic, we talk to the stakeholders and say, who's looking at it? Where do you want it? And make sure it's living in the right place, that it makes sense. A big common thing that we see now too is, in addition to putting data back into this EHR, is putting the data back into a respective data warehouse. So a lot of these kind of big IDNs have a Tableau or a Power BI, some sort of system where they like to centralize their data for quality reporting. and we can put data back there as well.
Mhm. Okay, thanks. And then Dimitri has a question. How does it compare with Photo Inc? I'm not sure
Yeah.
what.
So, I mean, Photo's a great product. I really admire the founders of Photo, PTs. We actually hire a lot of PTs. I would say Photo is very, I mean, the Photo's designed their own prompts, so they have their own scores, okay? Where code is survey agnostic, meaning you can administer any survey, whether it's custom built or validated through code. The other thing is that Photo was really designed for PT collection. So think of it kind of in clinic, on demand, kind of a custom. I want this patient to fill out a shoulder survey right here, right now. Code is more our infrastructure is more around that. So whether that's an encounter, the start of a treatment or a procedure, and we design what you want to collect and when, kind of prescriptively, and then it runs in the background. So Photos more hands-on, you're in clinic, you're filling out the data, you're able to kind of control what surveys and when, or code is a more prescriptive solution that is around an event.
Mhm. Okay, great. And we have another question, last one, unless someone asks more. We have plenty of time. Um, will you be doing any kind of webinar for marketers? In other words, they love to take this information and leverage the data on the hospital websites or patient-facing marketing materials. And more important, if you did have a webinar, they'd like to be turnkey and don't have to comb through all the reports to glean this great these great patient feedback comments to use as testimonials.
Evan, I feel like you're better suited to answer this question than I am. So go for it.
Well, no, that's what we do. That's all we do. I think this it came as an anonymous question. This came from an attendee specifically about how you could take the data that comes out of the pro surveys and turn it into marketing material.
I mean, I love this idea for us, Evan. I mean,
Hmm.
maybe we can take some real live examples and have a follow-up webinar that does that, right? Where we take some situations and then turn it into how can you market this? Because it is true. I mean, I used earlier an example of Evan, do you know what a cruise of a 40 feels like? And yes, I do. I could probably see somebody walking and tell you what their score is. How do you translate that to where patients would understand that you can market it? And then how do you actually market it? And that's where I think the power of our partnership really comes into fruition. Is
Hmm.
I can help say this is how you should package it, and then Evan, you're able to give it wings and say, all right, how do we get this out there to the world?
Hmm. Okay. Um, so that's more food for thought. I don't see any more questions. Just so everybody on the webinar knows, reiterate when we met Code, we did a lot of due diligence. We have mutual clients. We called our clients, and our clients are just absolutely head over heels in love with Code technology. So just a little plug for you, Breanna, and your company. You've built a great company with a sharp focus on customer service and satisfaction. So.
Thanks, Evan. And I mean, the feeling is very mutual. This was a very thoughtful. It's a big decision to trust another vendor, and we have trust in Raider 8 and what you do, and look forward to continually seeing our mutual clients just really collect, use, and leverage the outcome data and their reputation data to grow their
Mhm.
practice, make quality better, and you know not just for these payer programs, but why we all got into healthcare to begin with. Make a better experience for patients with better outcomes. And I'm confident that our clients will be able to use the information that we provide to them to do that.
Mhm. Okay, wonderful. This has been super helpful. I know we've went through the webinar before, but I think the one sticking point is the programs and the complexities and the timing. And if anybody needs a refresher or needs some material to share with others in your organization, this webinar is going to be. We'll send you a link. It'll be available. You could download it or watch it online, and then take screenshots, and you'll have all that information. Plus, you'll see in the presentation ways to contact us. And we hope we could get to work with you guys in the future. Thank you for everybody's time.
Thank you.